All right, let's talk about some birth injuries. So you see in your notes that you have on physical exam, a 12-hour-old newborn is noted to have non-tender swelling of the head that does not cross the suture line. What is the most likely diagnosis? Wow, I think this is out of... we'll get to that, okay? So we'll get to the actual diagnosis on this question. Okay? Let's talk about... We're going to get to that one. It does not cross the suture line, so it is a cephalohematoma. So, Faisal, had we been playing Jeopardy, I would have said, more specific, please. And then the judges would have said, you have to put cephalohematoma. So that means that Adaku and Jonas and Preeth, you get chocolates. Okay? All right, let's talk about some injuries. You have in your notes, before I get to this slide, okay, in your notes they mention the subconjunctival hemorrhage. This is very commonly seen in babies because as they're going through the birth canal, they can have some trauma, and so they can have subconjunctival hemorrhages, which eventually will fade away. Babies can also have skull fractures when they're first, again, the trauma of the delivery can cause skull fractures. Most skull fractures in these babies will be linear skull fractures, and they require no treatment whatsoever. Okay? And most of those babies are actually even asymptomatic. The brachial palsies include Herb Duchenne's, okay, and also the Klumpke's. Herb Duchenne and Klumpke's are brachial palsy injuries, okay? So Herb Duchenne's affects C5 and C6, and they will describe on the exam the waiter accepting a tip. It's the way that the baby holds its arm and hand that gives it away. When they want you to be suspicious for birth injuries, when you're reading the stem of the question, for brachial palsy injuries, look for shoulder dystocias. Look for traction on the head and neck during delivery. Things like that will make you suspicious for the brachial palsy, brachial plexus injuries. The Herb Duchenne's is C5, C6. Well, policemen don't accept the tip. Okay, Preeth, the waiter will, but not the policeman. They better not. Okay? Klumpke, with Herb Duchenne's, with Herb Duchenne's, sometimes you can have C4. Okay? With Herb Duchenne's, they can have C4 affected. And with C4, the dramatic paralysis. Okay? So there's another one. That's another way of asking the question or of expanding on the question. So they might say, and don't forget, you guys, step 1, step 2, step 3, specialty boards, subspecialty boards, they still over these questions, and it's the same stuff we're talking about here, just the same concept. It's a child with the same illness that you go across over and over and over again. Or what's the best test? What's the next step? What's the first step? And in step 3, it's what's the treatment? So it's the same subject. They're just asking different questions based on that subject, okay? So you might get, for example, in step 2, a question that describes a child with Herb Duchenne's. And they'll say C5, they don't say C5, C6, but they'll say a baby is born after a difficult delivery, shoulder presentation, or blah, 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 and on physical exam cannot abduct the arm. It is externally rotated and supinated at the shoulder. Or they might say the waiter's tip, or they might show a picture. And then they'll say, what's your most likely diagnosis? Or they might give you all of this, and you're thinking, oh, the diagnosis is Herb Duchenne's. But that's not what they're asking. They might say a little bit more. The patient is experiencing some respiratory distress. What is your next step in the management of this patient? And then you might get a chest x-ray. Or they might say the patient has some respiratory distress and a chest x-ray reveals, boom. And they might show you the chest x-ray, or they might describe the chest x-ray. And then they might say, what's your diagnosis? Okay? So when C4 is affected, they will have an ipsilateral hemidiaphragmatic paralysis. So on chest x-ray, you will see an elevated hemidiaphragm. Got a picture coming up in a minute. Okay? Elevated hemidiaphragm. And then they might say, what's your next step to establish the diagnosis? And then you would get either an ultrasound or do fluoroscopy to see if the diaphragm moves or not with breathing. They'll describe a baby that's not having respiratory, not bad respiratory, sympathetic ganglion. Now, with Herb Duchenne, they have the waiter accepting the tip. With Klumpke's, that's right, Jonas, they have what's known as the claw hand deformity. Okay? And they may or may not have a Horner syndrome. Here's another pearl. Horner syndrome. Horner's a guy whose forehead is dry, has a small eye, can't see the sky. Okay? Horner's a guy whose forehead is dry because they have dishydrosis, anhydrosis. He can't see the sky because of his ptosis, and he has a small eye because of the meiosis. Okay? Horner's a guy whose forehead is dry, has a small eye, and can't see the sky. Okay? Another mnemonic, since it's ptosis, anhydrosis, and meiosis, some people say Pam. Pam is horny. That's not me. I wouldn't say that. I don't want to get in trouble. I don't even know Pam. Okay, the majority of patients with Herb Duchenne or with Klumpke's will make a full recovery. Okay, usually this is a minor issue and they'll do fine. They may need a little bit of physical therapy. Very rarely is this a full avulsion. It's just traction. Okay, so they just need physical therapy. Okay? All righty. So I think I have pictures coming up. Okay, so if there's no recovery in 3 to 6 months, they need neuroplasty. Here's another hint for you guys. Don't throw away these notes. I'm warning you now. Don't throw away the notes. Don't sell them on eBay. Don't do anything with them except scribble stuff in them and keep them for step 3. Okay? Because a lot of this material in these notes, we're telling you about the therapy, which is what step 3 is all about. Okay? All right. So there we go. I knew I had some pictures. So here we have a patient accepting, there's your policeman from India, okay, accepting or asking for a tip. Okay, now I didn't say that. You guys said it first. Okay, And here's another guy waiting for a tip. And he might be a policeman, okay, because look, they blacked out his face so nobody would know who that officer is, okay? They're not asking, they're demanding according to Cayur, okay? Now, if C4 is affected, they can have an ipsilateral, so it'll be the same side. So this child has an herb Duchenne's here. If there is some respiratory distress, you get an X-ray. There's the diaphragm way up there. And it almost looks like a diaphragmatic hernia, but it's not. You can see the diaphragm way up there. And then you would get either an ultrasound or fluoro to see if it's moving or not. And it may need surgical application later in life. Okay, there's Klumpke. That's the claw hand deformity. And here's Pam. Pam is horny. Okay, this is a Horner's. Look at this eye, but look at just so subtle. Okay, just so subtle. That's ptosis. Look at the eyelids. And look at that pupil. And that pupil's a little bit smaller. Okay, so those are subtle findings. Sometimes it can be worse. So that's a Horner's paralysis there. Okay. All right, let's look at some other injuries. Okay, the clavicular fracture. Again, look for a difficult delivery, maybe a shoulder dystocia. Look for a big baby. And when the baby is born and it's delivered and you're doing your physical exam, you may actually feel crepitus. Many times the baby is asymptomatic. And at about a week of age, when the mother brings the baby in for a checkup, she'll say, I can feel a knot right in this area. Okay? And when you do your physical exam, you will feel the knot. You don't have to necessarily get an X-ray, but there you go. There's a clavicular fracture. It is the most commonly fractured bone during delivery and is associated with difficult deliveries in big babies. You can feel crepitus on physical exam. Crepitus is like bubble wrap. You can sometimes get an asymmetric Moro reflex. So instead of going like this, the baby goes like that. And the other one doesn't come up as much. Okay? This is not child abuse. Okay? This is not child abuse. It's not super displaced. You can see the knot at about a week of age because of callus formation. But typically it's not super displaced because don't forget, babies tend to be kind of chubby. And so it's hard to actually, you don't see a well-defined clavicle sometimes in babies because they're little and they're kind of chubby. So you have to actually palpate. And you just palpate up and down and palpate for crepitus. And the treatment is basically just immobilization, or sometimes you just don't do much for it. And in a few weeks, it'll get better on its own. A facial nerve palsy, okay, can include the entire face, including the forehead. And then when the baby cries, you would notice that the eye does not close and the mouth doesn't move on the affected side. Now, in step one, okay, let's go back to step one. In step one, they would draw like nerve tracks, and then they would put A, B, C, D, E where the lesion would be. Okay, that sound familiar? And you have to pick if it's the entire face, then that implies a peripheral injury. Okay? Those evil diagrams, that's right. If it's the whole face, it's peripheral, okay? Because don't forget that the facial nerve sends innervation from the opposite side. And so for the entire face to be affected, it's a peripheral. If just part of the face, then it's central. Okay? Same concepts. In this case, they'll show you a picture and they'll ask you to make the diagnosis, or they'll describe the baby and ask you to make a diagnosis. Those are the pearls. Okay? So it's due to forceps delivery or in utero pressure. And again, with most of these injuries, they get better over weeks. If the eye is not closing, you may need to tape it down to protect the cornea from drying out. Okay? And again, neuroplasty, if there's no, and that's what it would look like. So in this case, is this a central or peripheral issue? Very good. Rekha, Tanmayi, Denise, Mercy, catch your chocolates, everybody. This is peripheral, because if you look closely, the eye is closed, the mouth is drawn down, the eye is open, the mouth doesn't move. This is the affected side. That's peripheral. Okay? Everybody got that one right. Okay, so now we go to the baby that's described in our little vignette there. Okay? So there are different scalp swellings, and you need to know these. Okay? The two big ones that you need to know for the exam, okay, is going to be a Caput succedaneum. That is scalp swelling. Okay? So a baby that is stuck in the birth canal, okay, it's going to take, when it comes out, it'll develop swelling. Those are the cone head babies everybody talks about. Okay? But it crosses suture lines because it's of the scalp. If it does not cross the suture line, then you think of cephalohematoma. A cephalohematoma is a subperiosteal bleed. And if you look at this picture, there's the cephalohematoma right there. It is underneath the bone. It is limited to bone, and therefore it cannot cross the suture line. Now, sometimes you can be fooled, because a baby can have, for example, bilateral cephalhematomas. In that case, you would feel kind of like a groove in between the two swellings. Now, you can have some molding and this and that, but these are the two big kinds of swelling of the head that you need to be concerned about. And again, you leave them alone. The Caput succedaneum starts to go down in the first few days of life. The cephalohematoma actually might get a little bit worse, and it will take a lot longer. It sometimes takes weeks to get better. And you can sometimes feel, or they'll describe a crater rim or a volcano crater rim around where the cephalohematoma is. The groove appearance, so the groove appearance, you may get, for example, a depressed skull fracture, but that wouldn't be right where there is a suture line. You can get some molding. So babies can get some overriding sutures. And because remember, the sutures, the brain has to grow, but the sutures overlap during the delivery, and you can have overlapping sutures, and you'll feel a little bit of a step off, but there won't be swelling around it. That's how you can eliminate that. You can say that that's just overriding sutures. If they have a linear skull fracture, there's a little bit step off, but it's not where the suture lines are. That's how you eliminate that. Okay? You can have a little bit of a depressed skull fracture. But when you have the two types of swelling and then a groove in between, that's probably bilateral cephalhematomas. Craniotabia is very low. Okay? All right, so here, these caputs can lead to jaundice because it's a collection of blood. It's like a big bruise. And you have, I think, well, you don't have this little table, but I've explained it for you. Okay? It is that much that can cause jaundice. Cephalhematomas can cause jaundice because it's just enough blood that has to reabsorb, and you have a just enough immature liver that can't handle the increased bilirubin load, which we'll talk about later. Okay? All right. So there is a way of differentiating, which I've already explained to you. Okay? Caput versus cephalohematoma. Cephalohematoma does not cross the suture line. Okay, and here's a great picture. This is a baby with caput. That's a big cone head. Holy cow. That kid needs, when they knit a cap for him, they have to use extra wool, extra yarn. It'll go down days. Don't worry. Okay? This is a baby. It looks to have bilateral cephalohematomas. Okay? You can actually see the groove, yes. You do not need to CT or MRI these kids, okay? But you do see it right there. Now, recently, I was on, it would be worse if their heads weren't flexible. It would be worse for the mother, too. So I was on service last week, and we had a baby that came in at 14, 13 days of age who was having episodes of apnea and had to get intubated. And as part of the workup, had a CT scan done of the head. On physical exam, the baby had a cephalohematoma. That's not what was causing the problem. We'll get back to that issue later in life, okay? But they did a CT scan because of that, and it looked just like this. The cephalohematoma just looked just like that. So when they describe the swelling, okay, they might ask you to make the diagnosis to differentiate one from the other. If they ask you what is the next step in the management of this patient, it doesn't matter. Observation is the next step in the management of this patient. Okay? So they probably won't be asking that, but they might. And the observation is the correct next step in the workup of this patient. It's a clinical diagnosis. Both of these, clinical diagnosis, observation, is the best course of management. Gosh, I'm giving away answers. We're probably at about 34 questions, and we're in our first hour. Holy moly.